Please join me in welcoming Mr. Atallah.
I mean, from a more practical standpoint, my relationship with PAs is that I've actually taught and have been a preceptor for PA students year-round since 2011, mostly at Nova Orlando. So I have a very intimate, working relationship with PAs, mainly in training. How many of you guys are, show of hands, are less than 5 years out of training? Okay. And also, how many of you guys raise your hands if you're in a surgical specialty already? Okay, pretty much almost everybody. Okay. All right, that's good background. So I want this to be kind of dynamic and fun. I might call on you. I just want some, engagement. We have only like 10 or 11 slides to cover. So it's mostly let's have fun. I know a lot of this is for CME and we got to be here anyway. We want our credit, but let's have fun during this hour. And it doesn't have to be a whole hour. All right, let's just make it whatever it ends up being. So I also, let's see if, let me get it forward with this. Does this work? Yes. What's the secret to clicking the slides forward?
Point it towards the
Point it that way. Get a little aluminum foil. Okay.
Yeah.
This is the slide I wanted to show you. So Michelle Delin, who's the president, was my student 10 years ago. She's a Nova Orlando graduate as well. And she was a superstar from day one. Like I could tell you so many stories, but a superstar, A++ student from day one. And one day I did a lot of research back then, I still do, but especially at this time, circa 2015 or so, I said, I need to do an experiment that's never been done before, and I need to do surgery, and I need a volunteer. And she just raises her hand. She's like, you can operate on me. I'm like, no, okay, we're not doing that. But she did assist a lot in the structure and design of a new technology and operation. And that's actually her on the OR table saying, yeah, just do whatever you want. I want to be a part of this. That is the kind of enthusiasm that we love to see in students. And it is no surprise whatsoever that she ended up being president of ASPA. So congratulations to her, real superstar. So today, what we're going to talk about is small and large bowel obstruction. Sounds very boring, but it's actually interesting in the sense that the difference between small and large bowel obstruction is not just simply, one's in the colon and one's in the small bowel. End of story. Let's end the presentation now. But it's actually not that way. And understanding those differences, both in diagnosis and treatment, is really valuable. So let's take a vignette, right? We all learn from vignettes. I tell the students all the time, if you're studying physics or calculus or any of these kind of advanced math and you go to the lecture, you didn't grasp anything, and then you still don't grasp anything, but then you get an assignment where you do 12 questions or problems and you crank them out and then you get it. Vignettes are exactly the same way. They help us to understand things so that we're not just rote memorizing. And by the way, all of what you're going to hear and see today is practical. If you're a surgical PA in general surgery, colorectal surgery, seeing patients with pedestrian complaints like this, it's very practical information. So let's take a patient who, let's say, is 37 years old and comes to the ER with nausea, vomiting, and abdominal pain. First of all, raise your hand if you think that's a common presentation. Oh my gosh, it's all day long, every ER, nausea, vomiting, abdominal pain, nausea, vomiting, abdominal pain. Enough already, right? We see this all the time. And in many instances, nausea, vomiting, abdominal pain is not a surgical problem. You drank too much the night before, right? You ate something bad. Everyone else is sick at home. Go away, you just need an IV fluid and get out of here. But how can we quickly discern who isn't that person who just had too much to drink, who really has potentially a surgical problem, such as potentially bowel obstruction. So let me ask you a question. If you have this patient who came to see you in the ER, what line of questioning could quickly tell you this patient has a bowel obstruction, a small bowel obstruction, or this patient doesn't? What kind of questions would you ask? Anybody, go ahead.
What's your surgical history?
What's your surgical history? Great, I'm gonna put you on pause. What's your name again?
Andrea.
Andrea, okay. Andrea says, what's your surgical history? This is a very valid question, and I love it. But we're gonna put it on pause for a second. Any other questions from this guy's history? Nausea, vomiting, abdominal pain, any of those that you wanna know a little more about? Okay, maybe which one came first? What else? Other ideas?
That's gas. What was your last?
Okay, great. And I want you to, what's your name?
Jennifer.
Jennifer and Andrea. We're putting you guys on pause for a second. Excellent questions though. What else?
Where is your abdominal pain?
Where's your abdominal pain? Let's say he says it's just vaguely all over and it's cramping. I'm gonna ask you guys a question about the vomiting. All right, let's hone in on vomiting. Okay. What does it look like? Jennifer says, what does it look like? Why is that an important question, Jennifer?
Is it bilious or more stomach?
Okay, very good. What does everyone think about that?
Bloody or non-bloody?
Is it bloody or non-bloody? Is it bilious or non-bilious? Very good. This is exactly the very first question I would be asking this patient if I was down in the ER seeing this patient. I'd say, what color is your vomit? And I don't ask them, okay, first of all, they don't know bilious, right? They don't know what that means. Let me tell you, it's a hot take. What patients know with vomiting, every single one of them, whether they're 17 or 70, they can't wait to tell you what color. They cannot wait. Oh, I had some corn that I just ate. It was a little blood. I saw some mucus. Let me show you a picture of it. They are all about what they vomited up. They want you to know that, and they cannot wait for you to ask them that question. We have our little tuning antenna on because we've got how many of these patients we have? All day long, they're in every ER. We gotta quickly tell. You have a real problem, you don't have a real problem. With one question, we're gonna get that answer. And everyone has abdominal pain and it's very subjective. So that's kind of not background noise, but not the first thing that I go for. I wanna go for the vomit. Because I know my patients know it, and I want the info. And the info I'm looking for is exactly what Jennifer said. She said, what color is it? So there are basically two things that I care about. Honestly, I don't care so much about bleeding because most of it is trace blood. It's not a Borhaves most of the time. If it's really a lot of blood, of course, they're going to tell you that. Immediately, you're going to know, right? So what I do care about is if they say the word, the magic word that we're not going to prime them on, green. If you said green, you just went from the bucket of all you drunks, all right, to the bucket of somebody, you have my attention. You have just raised a red flag. So bilious emesis is a sign of a small bowel obstruction. So now, Jennifer and Andrea, what other questions are you going to now? And again, we haven't even got a convo going. You told me you're vomiting bile. My next question is, who wants to? What did you say earlier, Andrea? Yeah, now I want to know. Okay, sounds good. When was your last bowel movement, buddy? Oh, now that you mention it, I haven't had one in a couple days. Then we'll also ask the correlate, have you passed gas in the past couple days? Oh my gosh, actually I haven't. So I love this line of questioning and I love SBO because most of the time we're all around just poo-pooing the HPI, like, oh, I'm just asking questions. I'm going through the motions. I'm trying to pass my OSCE. My attending's gonna ask me or whatever. But these are actual questions that are pointed okay? And they're gonna get us quickly to the answer. I don't need a CT scan. I don't need to check your labs, and I don't need to run 6,000 diagnostic tests. You've already just now told me you have a small bowel obstruction. End of story. And we can now work in order down this line of what we're gonna do and how we're gonna manage it, and let's have a conversation about that as well. But you see, let's rewind this whole vignette. Oh, I've been having some vomiting and my belly's been hurting for a couple of days. Okay, what color is the vomit? Oh, it's green. Oh, okay, when was your last bowel movement? And you're passing gas. And if you're checking all those boxes, you just told us you have a small bowel obstruction. I don't even care what your imaging shows at this point. I do, but I'm trying to be a little facetious. But the point is, we're actually getting information out of a history with very few words. And I'll tell you what, most patients can answer all three of those questions. We love it when patients know something, like, let's go for the stuff they know because we need this info because we need to be able to treat you. All right, so this is painting the picture of a small bowel obstruction. Later in the talk, we'll talk about large bowel obstruction. Let's review the anatomy. I'm sorry, I found this on Google. It's horrible quality, but you tell it's a stomach. And really what I want you to see there and remind you of is the pylorus. By the way, how does somebody get bilious emesis? Like what does that mean? And how is another way of thinking about bilious? There's another way to describe bilious emesis, and we call that post-pyloric emesis. That's another way, valid way of saying it, versus gastric or pre-pyloric emesis, which is every other color that you can name, yellow and mucus tinge and bloodyish and food in it and whatever, but not the word green. So if you're taking down notes, green is the red flag. Green is the new red flag, okay? All right. So the pylorus. So basically your small intestine is dilating up and your pylorus can't handle it anymore. And if you're vomiting green, it's contents that's gone through the pylorus. Let's give you an analogy. I found this on YouTube just earlier today. Here's a dam. Here is a dam failing, okay? And this is the analogy. The pylorus is like a dam. It's holding all that bile downstream. Everything in the stomach doesn't have that. By the way, what is the actual color of bile? Does anyone know? It's actually gold. It's gold, but when it mixes with the succus and the chyme, it becomes green. And that's what we see, often a radiator green, okay? So the pylorus is the dam. Bilious emesis means we've broken the dam called the pylorus, and now we're barfing it up because of the backup, okay? Everyone else who's vomiting in the ER, they just drank too much and it's all gastric puke, okay? Very important idea. And then we can say, well, we can evaluate this. And if you're studying and researching for boards or on exams, this is favorite types of questions where they'll ask you things like, here's a good question. Okay, I suspect this patient has an SBO, small bowel obstruction. By the history that we just took on this 37-year-old, what's the best way to confirm whether or not this patient has a small bowel obstruction? Is it with an abdominal series or with a CT scan? Raise your hand if you think the answer to that is with a CT scan. No one said CT scan. Wow, why didn't you say that? Andrea, why didn't you say CT scan? I mean, wouldn't that diagnose it?
We're not ER doctors. That's why we didn't say CT.
Okay.
Sorry.
Honestly,
Put that out there.
that's facts. Okay, but what is the reason to not say CT scan? Because a CT scan absolutely would diagnose that. But is there any downside to a CT scan that it's not as right as another answer?
Not specific. It'll just show dilated small bowel loops, which could be enteritis or any other.
Well, I would argue and push back that a CT scan would be very specific. But I would say that the argument is, well, if I can learn the answer to this question with a simpler, examiners love this, a simpler study with less radiation exposure, then I would say get the abdominal series, all right? Because that would also give me the answer. But if the questioner said, I want to know where the small bowel obstruction is, then it's very valid that the abdominal series is not going to show us the answer to that. And you need to then have more advanced imaging like the CT body imaging. It's just good to think about those things, okay? Here is air fluid levels. All radiologists, they are all about the air fluid level. What this means, I don't want to spit, okay, well, let me do it. Now that I have the cap, we'll do it. Okay, so basically, just remember that if we have a loop of bowel and you're upright and you're taking an x-ray of me, here's my loop of bowel, and you take an x-ray, you're going to see the air fluid level, just like it's shown here with the PA holding it up, and that there's a line of water and it's vertical. And we see the exact same thing, lines vertical, air above the fluid. And what this is, you remember those old party balloons? Okay. Normally there's only fluid in here, okay, in small bowel. But just take that party balloon, imagine we put fluid in it, and then we blow it up more, so there's more air in the balloon and it's not just a water balloon. Then you hold it up vertical like these patients are standing upright, then we see those air fluid levels. Air fluid levels mean the bowel is distended, that's why we're seeing them. Okay, this is distended because if it's overblown with air, okay, there's more air than it can handle, so they show up as air fluid levels. And air fluid levels are the sine qua non or hallmark of a small bowel obstruction. Okay. And here's probably a better image of that. Very vertical lines, you see them? And we sometimes say this is a stair stepping or stacking of the stack of coins, lots of different ways, but basically we're talking about air fluid levels, and that's very important. All right, so we got this, and let's say we also, by the way, who can tell me what is the most common cause? I'm gonna ask Andrea, and someone who's had surgery, what is a common cause of small bowel obstruction?
Surgical adhesion.
All day long, surgical adhesions cause this. You've had prior surgery. That's why Andrea, from the before even getting any history, said, I know where this is going. Let me just tell you, let me find out what kind of surgeries you had. And so we asked this guy, let's call him Chris, he's 37, he's had 7 prior surgeries. So this is, and that was, we should have asked that in the history, right? Which we just put that on pause, but yeah, you've had 7. Now we even know the etiology just by the history, right? And we got this, and we've confirmed you have a small bowel obstruction. The most likely cause for a small bowel obstruction due to adhesions is in the terminal ileum, usually. So this is what we think he has. And we do an abdominal exam, you guys. And what is the second most common cause of a small bowel obstruction? Who can tell me that? Hernias. Okay, we examine him, and he doesn't have any hernias. Let's come back to the hernia small bowel obstruction in a second. But he doesn't have hernias. And let's say we also do a CT scan, which I don't have for this, I don't think. And he does have a transition point in the terminal ileum. The radiologist also, this is a catch phrase they use all the time. What they're describing is all the bowels this dilated, and then at one point it just became normal again. It transitioned to normal. That means that's the point where some adhesion in someone who's had prior surgery. Could it be something else? Yeah. Could it be a tumor? Sure. Can it be all sorts of other things? Yes. But most things, and common things being common, it's likely secondary to adhesions. All right, so we figured that out. We know his history. True or false? Raise your hand if you think the next best step, we got a guy with a bowel obstruction. There's no doubt about it. The next best step is surgery. Raise your hand. You're shaking your head no. What's your name?
Tia.
Tia. Tia says no. Looks like no one else also, or everyone agrees with Tia. Why not? Why don't we just, there's an obstruction. Let's go fix it.
Create
No.
more scar tissue.
Yeah, every
reoccurs.
time we operate, Tia's right, then we're just gonna have more scar tissue, and it's a catch-22, and we can't get out of this vicious cycle. So the mainstay, and what's another important reason, I'll just tell you, or you probably already know, but most of these small bowel obstructions due to adhesions, please be note noting and underscoring that in your mind. Resolve with conservative therapy alone. Okay? 80% or so, upwards of 80% of adhesional small bowel obstruction resolves just with conservative therapy. Who can tell me what is conservative therapy and what is, okay, Andrea, go ahead.
NG tube placement for decompression.
Perfect, all right,
NPO for
Okay.
benefits.
excellent, I love it.
And IV fluid.
Excellent, I could add nothing else, you are ready to go, and you're probably already practicing and doing this already, but for the people that are kind of newer or not familiar, that's what conservative therapy or bowel rest is, you know, we're gonna rest this system. But why does resting it make things better? And that's important to understand is what's happening here and how do we ever have any hope of getting this adhesion kink to resolve? In some ways, if you're familiar with a garden hose and if you've ever gardened, I now say this analogy to current students who are like, no, I don't know what I've never used a garden hose. And I'm like, are you joking? Okay, I know you guys are always on your phones and snapping and Snapchatting, but like get some experience in the yard, okay? So anyway, the garden hose analogy is you're going to water something and then all of a sudden there's no water coming out and you look back and there's a kink, okay? Surgery is analogous to walking over and manually fixing the kink. Conservative therapy is analogous to just wiggling this end of the scope and it unravels itself. And that's kind of what we're trying to do. But also it's important to understand that that bowel is very edematous. And when it gets edematous, that little tight adhesion point, the transition point, is even getting more stressed out. So we want to back it off, all right? The analogy that I use for this with the students recently is the idea of, let's say you have a ring on your finger. The more you try to take it off, the more swollen it becomes, the more you're not getting it off, all right? What do you need to do to get a ring off? Cool it down, put your hand up, get the blood out to drain, and then circle back and try, to do it. And that's the same thing. We're trying to cool off the bowel, only the way that we do it with bowel is we decompress it. And we have to be very cognizant though, because people can develop electrolyte derangements. If someone is vomiting, who can tell me what classic acid-base derangement they get? You have to watch out for it. You can't just like hook people up to bowel rest and NG tube decompression. First of all, their fluid status, we have to make sure we're keeping up the I's and O's with what they're losing, all right? But also, what kind of acid-base derangement? Does anyone know? Nobody knows? What? I finally got you guys to not know something.
Metabolic alkalosis.
Metabolic alkalosis, very good. Well, who said that? Very good, girl. Metabolic alkalosis with hypokalemia and hypochloremia and paradoxic aciduria, very good. All right, so we're gonna calm down the bowel and we're gonna fix things, right? Okay. And by the way, we said adhesions. This is an example of adhesions. What do adhesions look like on a CT scan if somebody has adhesions? Does anyone know? Anybody? Do they look like little white things? You know what they look like? Huh? Who wants to say? Anybody? I mean, well, I won't yell at you if you're wrong. Adhesions are invisible on a CT scan. You only see them if you see the obstruction or they're causing problems. So those adhesions that we see at surgery all the time, we're not going to see them on a CT scan. So we assume they're there because they're kind of invisible, all right? We definitely see them at surgery, but they don't show up on a CT scan. The effect of an adhesion certainly does show up on a CT scan. So those are all adhesions, or that is obstruction due to adhesions. Let's switch gears a little bit before we move on to large bowel obstruction and talk about the other main category of what causes small bowel obstructions, which is hernias. So now this is a little bit different. So let's say our 37-year-old, actually we ask him and he says, no, I've never had a surgery day in my life. Just to make it a little more simple. And we do an exam, but this time we see his belly button is falls down and it's tender and he's like, yeah, this has really been hurting me, and it's red around it. What does that sound like? All day long it's a hernia, but what do you think about it? Now we got to remember back to our, our class, and obviously there's a picture kind of probably prompting you. Remember incarcerated versus strangulated. What does incarcerated mean? It means the bowel is trapped in there and it can't get back in. But what does strangulated mean? Huh? What is it?
Trapped, but it's still.
It's more than trapped though this time.
Blood supplies.
The blood supply, yeah, there's something with the blood supply. It's not getting blood, all right? Okay, hot take and something to always remember. If you suspect somebody has a strangulated, there's no blood supply, meaning there's bowel in the hernia and it's lost its blood supply. The slide I'm about to talk about, okay? Do not try to reduce that. Call a surgeon, all right? If you're working in the ER, or if you're a surgical PA seeing a patient, say, hey, this guy has a strangulated, what you think or could be a strangulated hernia. Okay, that's one part of the problem. It's a big part, all right? You got dead bowel is a big problem, or ischemic bowel also is a big problem. The other problem, let's imagine in our 37-year-old, there's that knuckle of bowel and it's stuck in here. It's not only black and dying and dead, it's also causing bilious emesis and an obstruction. So now you have an obstructed patient with strangulated bowel in a hernia. So who wants to do conservative therapy for this? Bowel rest, NG tube, IV fluids. You might do some of those things, but absolutely not. Now this is a surgery now problem. This is a surgical emergency. You can't have somebody perforating their intestine and not addressing that aspect of it, let alone the obstruction. I added the slide of such a case. But anyway, this was a patient of mine who had, as you can see, that black bowel is not going to be alive and required resection due to a strangulated hernia. And, this patient also had an obstruction, but to a lesser degree. The main issue here was the strangulation. So see now, have we made this clear that yes, SBO, all day long, because adhesions are the most common thing. We're just going to manage that with bowel rest, IV fluids, NG tube decompression, but not in this scenario, by golly, no. And we're not even going to dare try to reduce that, because you're taking dead bowel, that black dead bowel, just shoving it back in someone's abdomen to perforate. No, that's not a solution. Very important to differentiate between those two. I don't think I did add that photo, but so any questions about that before we move on to large bowel obstruction, so we can start to make more sense of these two and just kind of compare and contrast them. So, and I'll start this and I'll say, to review, the most common cause of small bowel obstruction, hernias and adhesions, right? What about for large bowel though? What is it? A mass, a cancer. Absolutely. And so one thing less taught or less known is that the diameter, I don't think I can, but this is the cecum, okay? And the diameter of the colon, this is important, is larger on the right side. And then as you come across here, it's narrower. The other thing is the stool is more liquid-like on this side, and as you come here, it's much more solid. For this reason, tumors which grow from the luminal side tend to cause this blockage problem way more on the left side. So, to translate, left-sided malignancies are more likely to cause a large bowel obstruction. Now, there's another interesting thing here. So this is going to, let's see here, this is going to grow and block up this colon. So just like in our balloon analogy, the colon's going to get really, really distended and dilated, right? But what about the small bowel? Well, it's just going to also get dilated too, but no, it's not. So remember the dam analogy I gave you? The pylorus is like a weak dam. It can't hold anything. But this is a very strong and robust dam. The ileocecal valve, even though it's not a true valve, it's really robust. It can handle anything. It can handle a lot. There are some that are incompetent, but it doesn't matter. For the most part, they are very robust. So if you have a blocking growth on this side of the bowel, and this is constantly putting stuff into the colon, then the colon is getting dilated just like the balloon analogy I gave you, right? The colon is, but the small bowel isn't. It's really interesting. So on a CT scan, the small bowel would not look dilated, but even more interesting, these patients are not barfing up bile. Why? Because everything's moving downstream and being cleared out of the small bowel into the colon. The colon's having to deal with all that. So many times with competent ileocecal valves and a distal obstruction in the colon due to a tumor, these patients are very bloated up. Their colon is very distended, so they look bloated and distended, just like the small bowel obstruction patient. But interestingly, they're often not vomiting bile. They're not even vomiting at all. They feel weird. I don't know, like, look at my stomach. Isn't it big? What's going on? Are you able to eat? Yeah, I'm doing fine. But then we'll ask Jennifer's question. I think it was yours, or it could have been Andrea's actually. Are you pooping or passing gas? To that, it's a no. I will, with one caveat, sometimes if this is not completely obstructed, it ends up being diarrhea or liquid. Don't be fooled by the liquid bowel movement or diarrhea. So really try to get your grasp on that. Many of us in colorectal surgery want to know if you're passing gas to us. That's even more a sign that things are kind of moving through and then we have some time to buy. So I put some letters on to the colon map here. And this is also very important. So if we have that tumor growing and growing and totally blocking up the colon, and the ileocecal valve is that really solid, robust dam, it can just keep on cramming things into the colon and nothing going back. It's a great dam. What's going to happen to the colon? Blow it, blow it, blow it. It's going to perforate. Absolutely. That thing's going to blow. The question is, and I want you to start thinking about this now, is where do you think it would blow? Who, raise your hand if you think, and there's several points, if this was a multiple choice guess. Raise your hand if you think it's an A. Raise your hand if you think it's B. Raise your hand if you think it's C. 1. Raise your hand if you think it's D. Okay, a few more hands. And how about E? Okay, some of you may not have answered or played the game along. It's okay. Many of you said, well, it's going to perforate at the tumor. What are you talking about? But actually, that's not where we see it. And this is a good cross-reaching point that I'm going to make. And that is that, remember what I said, the colon is largest diameter on the right side. So the cecum actually is the largest diameter. There's a law in physics called the law of Laplace that states that wall tension is directly proportional to diameter. Okay? So the greater the diameter, the greater the wall tension, the greater the probability it will perforate. So for all the way across tumors over on the left side, all the radiologists are going to be hyperfixated on the cecum. This is why if you start to review in your mind, you may have heard this in lots of different scenarios, all right, where they're always talking about the cecum measures, the cecum measures, the cecum measures. What's their obsession with the cecum? The cecum can perforate. And why can it perforate? Due to the law of Laplace. What does it mean? It means it is the biggest diameter. So it's the one we watch in all instances when the bowel is dilated, the colon specifically. This can be an Ogilvy's syndrome, which is sort of an adynamic ileus of the colon. You're going to see the radiologist say, and measure it out with a little green mark. It's 6.8 centimeters or something like that. Normal is 6 to 8, 8 to 11. You start to become pretty concerned that it can perforate. Perforation obviously leads to sepsis, other problems, other things. Now you've got two problems and two separate zip codes to deal with, a tumor on one side and a perforation clear across the other side. Really is something we pay very close attention to. Patients with toxic megacolon, all right, a complication of UC, not this necessarily, but still, what are the radiologists looking at? Due to law of Laplace, cecal diameter. They're hyperfixated on it because they know that can perforate, and we're going to watch that. That's why we watch it, okay? So very important. So now we have a patient. And by the way, I don't know, I probably didn't say it. So when we have this scenario of just the colon distending and not the small bowel due to that very strong dam, the ileocecal valve, not like the weakling, the pylorus, and the colon's getting dilated, this is what's known as a closed loop large bowel obstruction. Unlike small bowel adhesion related obstructions, this needs a now problem. It's like the hernia with the incarceration and strangulation. This is a now problem. There ain't no NG tube that's going to fix this. In fact, if we put an NG tube in, what would it even do? The small bowel is decompressing. It doesn't even care. It's not even going to notice that you put it in the NG. It's not going to be very helpful. So bowel rest doesn't work. This needs an intervention now. And if you're not a colorectal person, which none of you probably are, or maybe one, or is anyone in colorectal surgery? Okay, one in the back, awesome. So most times this involves, let's just say, surgery. The name of the surgery can be a colostomy to decompress, like a transverse loop colostomy, take the tumor out. In some situations, an endoluminal stent can be used as a bridge to surgery. But the important thing is it's a now attention problem. This is not for, oh, we'll see you back in 4 weeks, okay? This needs the colorectal surgeon called now, or in some cases, the general surgeon, okay? Very important to make that distinction. And as a reminder, you know, tumors of the colon, they always start on the inner layer. You know, there's several layers to the bowel. The inner one is the mucosa, and that's the one where the tumors grow. If they didn't grow there, when we do colonoscopy, how are we ever going to find polyps? Just think about that. Polyps grow and turn into cancers. We never even see the cancers with a colonoscopy if they weren't growing on the inside. So they always start on that innermost layer, and they tend to grow into the lumen, blocking it. This is that view looking into a tumor. And you can see it ends, it's a roadblock. You can see beyond that little twisted point because the tumor has plugged the hole. Cancers are problems of the colon, not only because they are a cancer, it can spread and kill you, but also because they can classically on the left side obstruct, causing a actual mechanical problem. Okay, and that's important to keep note of. All right. I think we'll wrap it up with just a few more of these images to show you kind of what that looks like. This is a patient who had a large bowel obstruction. You can see the entire colon is markedly dilated, as is the cecum, the one place we watch more than anything else, right? And that's what it would look like. You can't see it on this cut very well on this coronal, but the small bowel is not dilated. It's all colon, all colon. And there's the cecum, okay, very dilated, and distal to that point of obstruction, the rectum is totally decompressed. That means we're on the other end. So in this cut, you see the cecum markedly dilated up to some point of obstruction that is out of view, and then the rectum is totally decompressed. And that's classic for a closed loop large bowel obstruction. And these scattered loops of small bowel, they are dilated because that ileocecal valve is patent. This patient isn't barfing bile either. A couple of special scenarios and things to keep in mind of. I love our nurses. They take great care of all of our patients, but they're not going to make a distinction between the type of output from a stoma. In some patients who have stomas, they will chart both of these as the same. They both have output. These are not the same, okay? Yes, we want to see the one on your left, the bilious, brownish, anything, stool looking. We don't want to see B, okay? That ain't any output. That's all mucus sweat. That means you have an obstruction. So don't be fooled and say, oh yeah, this is fine. Yeah, there was output in the bag. Don't tell your attending that, because that's not output in the bag. They'll look at that and say, no, we got a problem here, okay? So those are good little, caveats to keep track of. The other thing is, yes, large bowel obstruction, mainly an issue secondary to cancers. There we go. This is Anna Marie Conduct. She was my student at this time, a PA student, and we took this patient with a very classic sigmoid volvulus to surgery. So you can have somebody with a volvulus and it can twist on itself, the colon, and it can untwist, can torse and detorse, in other words. And sometimes it becomes a recurrent problem where we have to go. And when it twists on itself, then you know nothing's getting through it. So these patients can also obstruct them, right? And so one way to fix and resolve this is to resect the sigmoid colon. Sigmoid volvulus is very particularly common in infirm patients who may be institutionalized, that often are very cachectic or skinny, and surgery is actually not the first step for sigmoid volvulus. It's endoscopic decompression. The other place we see volvulus is over on the other side, the cecum, and if you have cecal volvulus, then generally the mainstay is surgical resection, and that's all you really need to remember about that. So we covered a lot. Usually after I give these talks, I do a table. Usually I'll just write it up, and I tell students, like, this is all just review. You should now, based on what we just covered, be able to make this table on your own and compare and contrast SBO and LBO. So what did we say is the etiology for small bowel obstruction? Adhesions, right? Also followed by hernias. What about LBO? Now we said, no, it's neither of those actually. And these are related to cancers, right? And the clinical presentation is also quite different. Similar in some ways, they're all obstipated, right? They haven't had bowel activity, they're not passing flatus. But the difference is for the small bowel population, they have the bilious emesis, but not in the large bowel due to that small bowel decompressing through the strong dam that can hold anything up, right? Like we said. And so for that reason, we don't see the LBO population generally have even any kind of emesis. What else? The key findings, we went over air fluid levels in the small bowel, stack of coins. I gave you the analogy, right? Okay, this is all about the air fluid level. Take a vertical x-ray of anybody with this. That's what our radiologists are looking at. And then the treatment, really, that's very important to stress that the treatment, right? In one of those scenarios, it was non-operative, right? The patient who had adhesions, we're going to bowel rest them, NG2 decompression, IV fluids. And, but for the patients with the strangulated small bowel, especially, we're not going to try to reduce that. We're going to call surgery immediately. That needs immediate attention, often a bowel resection. And for the patients with the obstructing colon cancers, absolutely, they need immediate attention, often by a colorectal. Well, those are all my slides. I hope you guys enjoyed that. Do you have any questions? Because we have a few extra minutes. I'm happy to entertain any of your questions. Yes, go ahead.
For large bowel obstruction, what helps guide your decision making between like diverting loop versus attempting an intraluminal stent?
That's a great question. Generally, the intraluminal stent, we're considering for someone at the bridge to surgery only. We want to decompress them. Why do we want to do that? So we can take that caliber of dilated colon and make it normal. That will make resection and primary anastomosis much more safe and feasible. So it all depends, it's all case selective, right? The main thing in somebody that presents with that closed loop large bowel obstruction and a cancer, the priority is the obstruction, and we want to resolve that. So sometimes, let's say it's a very low tumor, maybe they would benefit from adjuvant therapy, especially in rectal cancers that are obstructing. Then we want to divert them, fix the blockage, get them into treatment. If it's neoadjuvant, chemoradiation, something like that. Yeah, good question, great question. Any other questions?
I have one.
Oh, go ahead.
With recurrent diverticulitis, flares and perfs, how many episodes before you say you really should have an elective resection of this?
Well, that's a great question. Difficult to answer, and we often individualize it. I mean, for younger people, especially who have had more than, let's say, 3 significant attacks in which, especially if they've been hospitalized, we'd say, you know, you'd probably benefit from an elective resection. What we find is that episodes tend to become closer together and more significant over time.
Right.
And so I think it's valuable, but let's say you have someone who's maybe older, maybe has some comorbidities, heart disease, et cetera. So those are often individualized and there's no hard and fast rule about that. One thing that we usually stick to, however, is that patients have complicated diverticular disease, right? Complicated diverticulitis. Then they're in a different bucket. These aren't just recurrent, simple, uncomplicated. They require often surgical attention. Certainly, if you have somebody with a colovesical fistula, then those patients are never going to get better with antibiotics, right? And they require surgical intervention for sure. So there's certain criterion that we say, okay, well, this automatically you would benefit from surgery. But I got a question for you guys along the lines of diverticular disease. This one seems to come up quite a bit. How does somebody present? Does somebody with diverticulitis have bleeding? GI bleeding? She said no. Why? I think you're right, but yeah.
Diverticulitis bleeding, but like
Yeah.
diverticulitis is just an inflammation.
Very good. And I think this is the point that you're spot on, okay? I don't think a lot of people know that actually. And I feel no one's very clear about what exactly does diverticular disease do. There's 3 scenarios, okay? You have diverticulosis by itself, all right? And the natural history of that is, you know what, in most patients, nothing at all, doesn't do anything. It's there, it's a note, it's noted, you have diverticulosis. The other scenario that sometimes diverticular disease with diverticulosis can cause is bleeding, tremendous bleeding, but it's not an inflamed colon. It's completely uninflamed. Usually it's a perforator artery or vessel that bleeds all of a sudden. And you can have massive lower GI bleeding. In fact, it's the most important cause of massive lower GI bleeding. So that's good. But it's mutually exclusive. If you have diverticulitis, the inflammation form of that, you're not going to have GI bleeding or massive GI bleeding. It's a completely separate entity. So you're totally right on that. But I think that's somehow lost in translation. And I see a lot of my students, current and past, are always asking about bleeding, but that's not really the emphasis at all in diverticulitis. Good question and good point. What else? As far as bowel obstructions go for the diverticulitis population, that certainly is something, if you have chronic diverticular disease over and over, most of it is smoldering and never really resolves, but you can get patients develop strictures that cause a blockage. In fact, that's the number 2 cause of a large bowel obstruction is diverticular stricture. Very good, good points. Anything else? You can ask me about anything else if you want. We don't have to talk about LVO, SBO.
How do we
You
get,
missed the slide that we did about you.
About me?
Yeah. Should we rewind it?
Yeah, let's see.
Okay. Yeah, there's only like 10 slides, let me see. Any other questions while we're waiting for that?
how do we get ER doctors to not call general surgery for constipation? Any advice?
I wish I had that advice. I mean, they're always gonna call us for everything, right? Well, I would show it to you, but I can't even, how, can someone help me click this back?
Kevin.
Kevin, help. Oh.
The smaller book, above the shape book,
Can you go back to my first slide? Please, thank you. Huh?
the remote had a back button.
Oh, I tried to, and it's not. Only the forward one is working, but thank you. Okay, he'll do it, okay. Stop right there, no, go. I was just, you missed it, but I was just saying, yeah, I mean, all-star student from day one and everything, and I was just telling the story of how I said, we need a volunteer to do experimental surgery on it, and Michelle's like, I will do it, I don't even care. Like, this is the kind of energy, enthusiasm, and the kind of attitude and approach that we love to see in all students, enthusiasm. Obviously, we never did a surgery on her, but she helped us in a lot of ways to plan an operation. And she was a go-getter from day zero. And it is no surprise at all that she became the ASPA president. So congratulations to you, Michelle. This was probably 10 years ago now. We're dating ourselves. Yeah. So.
Dr. Atallah, I just want to say thank you so much for being here.
Thank
You
you.
guys, he's been so influential in my career. The first one to teach me how to suture on a real life patient and to brace myself with my pinky.
Yes.
I still use that today. And
And a quick plug for our book that's coming out. We wrote a book entitled Fundamentals of Surgery for Physician Assistants, and Michelle has written the foreword to that book. So look for that. It's going to be published probably by December, Springer Nature.
Okay.
Thank you. Someone else. Good to you. Okay, awesome. Any other questions from you guys? Okay, you were great.